Medication management is important, especially in older adults. That's why medication is one of the 4 M's of the age-friendly health system. Medication management touches us all and requires a complete team effort. It takes all disciplines and settings being actively involved to safely use medications in a patient and family-centered approach. We all have a role to play. So as we go through things today, I really want you to keep that in mind. And also, before we really dive into things, let's set the stage for this presentation today by reviewing the 4M framework of the age-friendly health system. If you've attended previous webinars in this series, you're aware that the 4M framework includes what matters, mobility, mentation, and medication, the focus of today's event. Utilizing the 4M framework results in high-quality geriatrics healthcare. It's important that all 4 M's be delivered together reliably with every older adult encounter across the continuum. Why is that? Well, because each of the 4 M's are interconnected. Let's use medication as an example of this. Medication is connected to mentation, where medications can affect someone's mentation, and mentation can affect the ability to take medications correctly. Medications are impacted by mobility and can impact mobility. They can affect someone's balance and their gait. And what matters needs to be considered in medication regimens and when to add or remove a medication. So implementation of the medication M in an age-friendly health system includes the identification of potentially unsafe medications and identifying opportunities to deprescribe. In addition to deprescribing, there's also making sure necessary medications are properly used and adhered to. And there are also screening tools, some of which we'll discuss today, that can help with that assessment. So with that framework in mind, here are today's objectives. We'll discuss some of the impact and prevalence of polypharmacy in older adults. We'll identify high-risk medication classes that contribute to polypharmacy and adverse drug events. And we'll review available resources and tools that can aid in our deprescribing efforts. Medication management is important because potentially inappropriate medications can lead to adverse drug events, which decrease our health outcomes and can lead to unnecessary acute care utilization and costs. For example, New England Journal of Medicine study referenced on this slide estimates that 100,000 adults in the US age 65 or older have emergency hospital admissions annually resulting from adverse drug events. Almost half of those occur in the old category of adults aged 80 or greater. 2/3 of these hospitalizations were due to unintentional overdoses, and there were 4 classes of medications that were involved in 2/3 of these administrations. So 4 high priority drug classes, including diabetic agents, anticoagulants and antiplatelets, and opioids. Other studies revolving around adverse drug events have found ADEs to be the cause of 3.5 million avoidable office visits a year and over 1 million avoidable emergency department visits annually in the United States. So studies and facts and figures like these led a multidisciplinary group to create the National Action Plan for Adverse Drug Event Prevention in 2014. The National Action Plan has been the foundation for the federal government's response to adverse drug events, including their response to the opioid crisis. It uses a multi-pronged approach focusing on high impact targets and populations for ADEs that are common, clinically significant, preventable, and measurable. A major contributing factor to adverse drug events is polypharmacy. which in its simplest definition is the use of multiple medications. For practical purposes, we usually define polypharmacy as taking 5 or more medications. And this is not limited to prescription medications only. This definition should also include non-prescription over-the-counter medications and supplements. What makes older adults prone to polypharmacy? Well, there are many factors that contribute to this. One is simply what I'll call the accumulation of medications over time. When many adults hit middle age and begin to start taking medications in small doses to help with common chronic conditions like blood pressure, cholesterol control, what happens once these are started is we have a tendency that once we start a medication, even if it's effective or not, we often continue on it as long as there's not some sort of severe adverse reaction to that medication. These meds continue, and over time doses are increased and additional medications are added to either help manage that condition or others, and we just see those medications accumulate. As we age, we also end up with multiple providers as we begin to see specialists. This highlights the importance with these multiple prescribers of medication reconciliation and having up-to-date medication lists with every provider that's seen. And of course, chronic conditions have a major impact on medication load. According to the CDC, 56% of adults age 65 and older have 2 or more chronic conditions, and almost a quarter of them have 3 or more chronic conditions. These conditions often require multiple medications to manage those conditions. One example is the multiple medications needed to manage heart failure. This is also true with diabetes, hypertension, and other chronic conditions. Finally, I wanted to close this slide out by circling back a little bit to the point made earlier on this slide that once a person starts on a medication, they often continue on it, regardless of their effectiveness. This can be true for medications started as a standing order during a hospital or rehabilitation stay. A prime example of this that we'll talk about a little bit later is the use of proton pump inhibitors. Also contributing to polypharmacy is the fact that in general, prescription drug use continues to increase at a rate that is not just attributable to our aging population. We have more and more drugs available to us and more conditions to treat. I often say that just like we often hear there's an app for that on our phones, right? Where there's an app for anything that we need help with, it seems. We can also say there's a med for that when it comes to our health. And it's really easy to default to using medications as our initial response when some sort of treatment is needed. This NHANES study here on this slide showed that overall prescription drug use increased 9% from the year 2000 to 2011. And during this study, they also found that those taking 5 or more medications increased from 8% of the population to 15% of the population. And I don't have more up-to-date data on this, but I'm certain that the 2021 numbers on that, the prevalence of that is even higher than it was a decade ago. This same study showed 2 in 5 adults age 65 and older take between 5 and 9 medications, with almost 20% taking 10 or more medications. I've seen more recent studies that show that 5 to 9 prescription range could be as high as 60% now. So we have even a greater amount of individuals that are older adults that are meeting the definition of polypharmacy. Now, not all polypharmacy is bad. If medications are indicated, complementary, and beneficial, then polypharmacy is acceptable. However, when we get into medication overload, this is when we see those unnecessary medications. And there's kind of some different ways that we can categorize unnecessary medications. And these include those that are never necessary. And an example of those would be a medication that's prescribed simply just to treat the adverse drug effect of another medication. There is the example that I kind of discussed earlier too, where the medication is indicated but not beneficial. We're just continuing with the med even though we're not seeing the benefit that we intended to use it for. It's just not working, but yet we never discontinue it. We also could categorize a medication as no longer necessary. So it might have been necessary at one point in time, but is no longer necessary. Some examples here include statins in those that are older. We'll talk about that in a little bit, as well as daily proton pump inhibitor use. And there's a final category that we can look at with polypharmacy where, again, these might be unnecessary medications, and that's involving over-the-counter meds and supplements. Again, we don't want to bucket this just with prescription medications, but we want to include everything that's being taken. It is these unnecessary medications that lead to a medication overload and can lead to or result in a prescribing cascade that leads to an adverse drug event. There are estimates that the risk for an adverse drug event increase by 7 to 10% with each medication that's added to a regimen. So when we consider that we have 60+% of our older adults taking 5 or more medications, their odds of an adverse drug event are quite high. What is a prescribing cascade? What do I mean when I refer to that? Well, a prescribing cascade isn't as beautiful as the cascade in this artwork on this slide, but it can be just as dangerous. Those are definitely some rapids there that have some danger to it, and so can a prescribing cascade. The definition of a prescribing cascade is using another medication not to treat a medical condition, but rather to treat the side effects of another medication. And a little bit way of viewing it here is on this slide, where a medication causes an adverse drug event, which then either is misidentified as an illness, which results in another medication being prescribed, which then leads to potentially a drug interaction with that original medication, or another adverse drug event, which then gets us in this cycle again, where we are prescribing just to treat medication side effects. The cascade begins when, instead of changing the medication causing the adverse event, so instead of treating it at the root, we add another medication to treat the symptoms. We're avoiding that baseline cause. OTCs and supplements are also a contributor to polypharmacy. It's important to obtain a complete medication history list, including over-the-counters and supplements. It's estimated that 50% of patients do not inform their providers of all non-prescription medications, and this can lead to adverse events. An example of this is ginseng's effect on blood sugar and potential for hypoglycemia. There's also a lot of considerations with over-the-counter cough and cold products and their potential effect on hypertension, and also accumulation of acetaminophen when used in combination with other pain relievers. And there's also, that we could go through a huge list of examples with interactions with warfarin and many commonly used supplements, which then can increase our risk of bleeds or our risk of clotting, depending upon which way the supplement has an effect on the blood thinning properties of warfarin.